Okay, so I'd like to talk about arthritic knees, degenerative knees. Most of the patients that we treat, they come in, they've had some x-rays, possibly some MRIs. They have what's called bone on bone knee. Basically, the knee joint is sort of positioned like this, and it should have a cushion in there that's cartilage. And as the knee becomes arthritic, that cartilage continues to thin until we have a bone on bone situation, which is very uncomfortable. Now, the body's protective mechanism of this is to create spurs going from the top bone to the lower bone and eliminate motion, right? So it sees it as a weak spot. Those are the arthritic spurs and sort of the advanced generation that occurs with that. And the reason I mention that is when we treat those, we do address those spurs, and it's very important. So most of our patients, when they come in, unfortunately, they wait until it's like a bone on bone situation. It would be much easier to treat them, and it would be more effective to treat them if they came in, a little bit earlier on in the arthritic process. But unfortunately, most of the patients wait until they have a bone on bone situation, and that's what we're treating. So, me and our clinics, we had 6 clinics in Florida we did a study for Medicare over a period of 36 months. And Medicare wanted to find out, would regenerative medicine handle a bone on bone knee so the patient would not need knee replacement? So we went about our study. It was an 18-month study, and then it was extended for another 18 months. And it was very interesting. We learned a lot about how to treat these knees with regenerative medicine. In the early days, we thought we'd put some stem cells into the knee, and stem cells are like a seed that can grow into new tissue. And the coupling factors around the stem cells, they go in there and they chew up the scar tissue, including those spurs, right? Very, very effective. So, and the old theory was, well, that you put 10 million stem cells in a knee and, the knee should recover. Well, what we found is about 20% of those patients actually recovered. So obviously very frustrating for those patients. And if the patient was already, with a cane in a wheelchair or something like that and not mobile, really limited chance of them doing well with that. What we learned during our Medicare study, they used a very I'll say a very low quality product. It was very regulated, the product that we were able to use. But the benefit was we could do an injection every month on the patient as long as they hit medical necessity. They had weakness, they had a limited range of motion, they had these factors that said, okay, you have a diagnosed arthritic knee, you can get another injection. So the patients would come in every month, and for a period of about 6 to 8 months, they would all hit medical necessity. So we would put a very low quality regenerative product into their knee, and 78% of these patients recovered to the fact that at that point in time, they did not need knee replacements. So just a fantastic study, worked out great, very positive for the patients. Everything was good with that. The study ended, and therefore, we didn't follow up with the patient. This is about 4 years ago. No, it's actually, this was, I think, before COVID. So we didn't follow up with the patient. So we don't have a really good prediction on how long it lasted. But during that period of time, the patients that came in, they needed knee replacement surgery. They were all bone on bone knees. We treated them on average about 6 to 8 months with one injection per month, and 78% of them no longer needed a knee replacement. And you can see on an x-ray, of course, if the cartilage is gone, and if we do regenerative medicine and we regrow the cartilage, when we take another x-ray and we see now a space, it's no longer bone on bone. You don't see the cartilage on the x-ray, but that's what's causing the space is the cartilage. So we have a regrowth of the cartilage. So we became very experienced with the different qualities of regenerative medicine. And we found that a balance between using sort of a really high quality product and multiple uses of a lower quality product, that this was very important. So, and what we've been working with more recently is an advanced regenerative matrix. This is a highly specialized product. It's a placental material that is incubated for 30 days. And there's a number of pluses with that. Number one, we get a very high concentration of regeneration and growth factors. But with any product that we get from, say, an umbilical cord or an amniotic tissue that we may use on a wound or something like that, if that patient that is the donor of that tissue has something like hepatitis or HIV or cancer or something like that, we run the risk of giving that patient that problem. And of course, we don't want to do that. So when we use a regenerative product, certain labs will, let's say they get 100 vials of, Wharton's jelly that has stem cells in it and other growth factors. They take 10 of those vials and they test them and make sure, some labs will only question the mothers before the mother delivers. Do you have hepatitis? Do you have HIV? And so we don't get really accurate information with that. We do not work with those labs. So we have never had a problem with imparting, any of those problems in our patients. But the beauty of working with the Advanced Regenerative Matrix is that concern is completely eliminated. There's no concern on that. And the benefit is we get a higher concentration of growth factors. That higher concentration of growth factors, though this product is more expensive, that higher concentration of growth factors requires many less injections. And, the good old days of injection one and being done, well, and probably 70% of our knee injections, we just use, ARM, Advanced Regenerative Medicine, and that's it. Now, some of those patients do need a booster, and there's nothing wrong with that because we're still fixing the problem that they came in for. As compared to maybe one of the other products that we would use that very little, but do carry a risk with them, we have to use those multiple times, right? So, and there's sometimes reasons for one or the other. Mainly, I would say financial, or, we have a lot of patients that come in to our Tampa or St. Pete office from out of town. And so they want to get as much done on their one visit as possible. And the Advanced Regenerative Matrix is the key to that. I mean, it's the best product that we've worked with in my, 10 or 12 years of using it. So that's how we handle bone-on-bone knee arthritis. So sometimes I get asked, how is the knee injection done? We use a specific procedure. It's called a video fluoroscopy. It's basically where the X-ray and the screen are able to move, and we can position it, and it shows motion. So when we're injecting into somebody's knee, we can see the needle on the screen from the video fluoroscopy and know that we're putting it in the right spot. I mentioned we did a study for Medicare. We had to document that each one of our injections was actually going into the right area to do the maximum benefit. So each of our injections was done with a video fluoroscopy. So a lot of times patients will ask, is it painful? It's not painful, but I would say it's uncomfortable. We cannot use lidocaine to sort of numb the knee because that has a negative effect on the regenerative products that we're introducing into the knee. So we can't do that. Now, that's good and bad, right? Because you can't numb the knee. You're going to feel something. But it's not so severe that, you need to numb it or you need to, use some sort of painkiller or something like that. We really wouldn't do that because, it would decrease the effectiveness of the regenerative product we're putting in. So there are times where maybe the patient is really sort of scarred up and it can be a little uncomfortable. Nobody's had a problem with it, but, it is an injection and we do go into the knee. We use a video fluoroscopy to see exactly where that needle is going before we introduce the material of regenerative medicine into that. The other thing that's important to know is this is not considered mainstream treatment from a standpoint of insurances. Insurance would much more rather pay for a knee replacement, even though 4% of the patients die on a table and there's risk, and if they don't do the therapy, there's all these components of really negative things that can happen with a knee replacement, though many of them are done. This is a self-pay service, right? And again, that basically means that the insurance companies are not going to pay for it. Regardless of who does it, they're not going to pay for it. It's very funny. We helped an orthopedic surgeon in Tampa, and he had done thousands of knee replacements, and he was about 72 by the time we met him. He had torn his Achilles tendon. He already had sort of knee, hip, and back problems. So this limping around was really affecting his knee, hip, and back, you know. And I said to him, I said, let's put some regenerative medicine in there and see if it'll grow. Oh, that stuff, you know, I don't want to be bothered with that. So after about 2 weeks of this, and he's actually getting worse, and now it's starting to cycle in through his hip and his back because he's walking so poorly. He says, okay, let's give it a try. Well, within about 2 weeks, you can see on a follow-up ultrasound, number one, you saw there was complete separation, right? Pretty major tear. You can see in about 2 weeks that it was starting to come together and there was fiber starting to mend and grow together. And ultimately, in about 6 weeks, he didn't have a full recovery, but he had a much better recovery than, and he was a surgeon, again, an orthopedic surgeon, than if he would have put a mesh in there, had that whole surgery. So he was very happy about it. And we just thought it was funny because he started offering regenerative medicine to his patients instead of doing knee surgery. So it was just sort of a funny thing that happened. But I just wanted to let you know it's not covered by insurance, so it is an out-of-pocket expense. And the range of price is usually somewhere around $3,000 to $5,700 for an injection. And the only thing that changes the price, obviously, the doctor gets paid a certain fee to make the injection. The thing that causes the different price is the material that we use within the syringe. And we buy that, and then we turn it over to our patients. So again, many patients that have come to us, and we actually do this service, so we're very familiar with. And you know, a lot of patients call it the chicken gel. You know, it's an injection into the knee that should offer a little cushioning, lubrication, and support, and it's somewhat effective for a temporary relief. It doesn't stop the degeneration like a regenerative medicine injection will. It gives the patient a little comfort and it gives them a little better range of motion, which are all positive things. It doesn't do anything that's damaging as compared to like a steroid injection. So many patients will have a steroid injection before they come and see us. So a steroid injection will last anywhere between 2 weeks and 2 months. And so the patient, he feels a reduction in the inflammation, therefore they feel less pain and they have a better range of motion. The problem is, and this has been proven, you know, for many, many years, that steroids in joints accelerate the arthritic process. So if you look at this for a second, we're actually treating the joint because the arthritis has gotten so bad. It's an advanced arthritic condition. And then we're introducing a product that will give a short-term relief, but make the condition go downhill even faster. So it's not really a very good treatment. Usually patients will have, I had one patient actually that had 24 steroid injections before we fixed her knee. And that's a lot. That's a lot of strain on the liver, a lot of strain on the kidneys and the other systems. And I think it was a heavy component as to why her knee degenerated and became so arthritic, so advanced, because there's no question about that. Any doctor will tell you that. Yeah, you may get relief for a couple of weeks, but it will accelerate the arthritic process. So I would stay away from steroid injections. The chicken gel is, you know, it's when the cost of regenerative products have come down so much over the past 4 years that, you know, the cost of the chicken gel, soup parts, and these other products, because they require, you know, 3 to 6 injections, you have to pay for each injection. The cost of those things really start to compare the same cost as a regenerative product, which has the added benefit of, number one, chewing up the scar tissue, and number two, regrowing and replacing the damaged tissue, including the cartilage. So if you look at maybe a cost analysis basis, you're probably better off going initially to the regenerative product rather than the soup parts or the chicken gel, as most of our patients say it. So we're doing a lot less of that now anyway, because the regenerative medicine has become so cost effective.